Hi and good afternoon, everyone. Thanks for joining us. Welcome all to today's School of Public Health noon meeting seminar. I'm presenting today. My name is Benjamin Kagina, and I co-direct Vaccines for Africa Initiative. And also I direct a new project, which I'm going to speak about much later. So my names are Benjamin Kagina, and I co-direct VACFA, which is Vaccines for Africa Initiative. And also I lead a project that we call it NISH, and I'll speak more about NISH. It's the last goal of this presentation. So today I'm going to be talking to you about the evidence-informed decision-making for vaccines and immunization, looking at the past, present, and the future. So moving to the next slide.
Use the arrow key on the keyboard.
Yeah. So I've got 4 goals for today's presentation, and the first one is to contextualize how evidence-informed decision-making is applied in vaccinology, and also highlight how the national immunization programs have been evolving over time. And then briefly talk about evidence to recommendation, which is pretty much evidence-informed decision-making process. And lastly, we'll end by talking about the NISH, which is part of a project that VACFA is undertaking, which directly contributes to the evidence-informed decision-making in the field of vaccines and immunization. So I believe I do not need to tell this audience about the importance of vaccines and immunization, but I thought it's really worth reminding you how vaccines are critical in terms of health, economic, and social well-being, in terms of positive impact the vaccines have. So if you look at health specifically, we know vaccines reduce morbidity and mortality associated with infectious diseases. And a key highlight of the success of vaccines and immunization is the eradication of smallpox, and I'm going to speak to that later. I've got a slide on that. And also, I think when you have vaccines that is widely used and the uptake is good, you induce what we call population immunity, which means that disease does not spread within communities, and that is very good from a public health standpoint. Importantly, we know that antibiotic resistance has been a global public health issue, and vaccines use, especially widespread vaccines use, has been shown to prevent antibiotic resistance. And then on economic side, we know that those people who are up to date with vaccines and fully vaccinated get sick less with vaccine preventable diseases, and that results to cost savings. And also people who are fully vaccinated get sick less frequently, again, due to vaccine preventable diseases, which results to improved productivity gains. Also in terms of dealing with outbreaks, we know that communities that have high immunity to vaccine preventable diseases have less risk of experiencing outbreaks, which are very costly to deal with. And then from the social side, it's vaccines advance equity and reduce poverty, and also the empowerment of women. So it's not surprising that when you look at sustainable development goals, vaccines and immunization are very central to attaining those most of those sustainable development goals. So when we talk about evidence-informed decision-making, I'm sure most of you may be wondering, what does it entail? And this slide speaks to this. It's the identification, appraising, and mobilizing of the best evidence for safe and effective vaccines and immunization policies. And what is important here is that another component which I haven't added here is the generation of evidence, especially for those of you who are involved in research. This definition of what it entails, it's actually look more on the usage of evidence. But if you look at the generation of evidence, which is a very important component for researchers, it's also part of evidence-informed decision-making. And when we talk about immunization and vaccines policies specifically, evidence-informed decision-making has been shown to improve effectiveness of the programs, efficiency of the programs, equity, transparency, and accountability of decision-making, and use of resources, and very importantly, it has been shown to reduce research waste. So when we talk about evidence-informed decision-making in the context of vaccinology, one might ask, where is evidence-informed decision-making applied? And the answer to that question is actually it's the entire life cycle of vaccine development. You use it as early as discovery and early development to late development and implementation. So this is a nice review showing the key to this message that you need to get from this slide is that we use EIDM in the entire life cycle of vaccine development, from preclinical to late clinical and implementation. But what has been shown here is that in the past, when you looked at vaccine development life cycle, it's a lengthy process, which is hugely resource demanding, taking approximately 20 years. And what COVID has taught us is that there are some aspects within this process of vaccine development that can be modified to make sure that vaccine that have been shown to work based on evidence can reach the population that needs them most without waiting for such a long period. So in between these two, I mean, I can point here for in between 2015 and 2025, these are some of the strategies that have been shown can be modified to shorten the period from discovery to implementation. And if you look at this part of the real world data in 2025, what the projections are, by use of evidence, we can definitely shorten the time it takes from discovery to getting the vaccines to real world. So, and also I'm sure some of you are asking, well, when it comes to evidence-informed decision-making, what types of evidence are we talking about? And this is a nice pyramid that shows different levels of evidence, with the top part of the pyramid indicating the secondary or pre-filtered studies which have been collated and synthesized. And this is considered some of the best highest level of evidence. Of course, you need to look at the quality of these clinical practice guidelines. You need to look at the quality of these systematic reviews and meta-analysis. But at the top, those are considered to be the best levels of evidence. Then others, epidemiological studies, such as randomized control studies, which are experimental. And down below the pyramid, you've got the observational studies and other sort of studies like case reports. So largely in this case, I mean, the pyramid indicates that with preclinical studies, which are animal and laboratory studies, we haven't been able to use evidence for that in vaccines decision making, but that is incorrect. Now we're seeing more and more evidence being demanded by the regulator before a vaccine is approved on the data that has been generated at preclinical level. So at the top of the pyramid, it has been fairly the standards, the clinical practice guidelines, meta-analysis, systematic reviews, and RCT. Those are the main kind of evidence that has been used to issue vaccines and immunization recommendation. And we know currently that at global level, the WHO uses this kind of evidence, the secondary aggregated evidence to issue the WHO vaccine position papers. And it takes quite some time to prepare these position papers based on the highest level of evidence and best quality evidence. So coming to the second part of my talk, which is the evolution of national immunization programs, there was quite clear conviction by public health community that following widespread use of smallpox vaccine and eradication of vaccine, that vaccines were central in fighting infectious diseases and advancing health generally. So when the program, expanded program of immunization was started in 1974, only 5% of the world's children were protected from the 6 antigens that were included when the program was started. And it was easy at this stage for all the countries, pretty much globally, to use these 6 antigens, which is BCG, diphtheria, tetanus, polio, measles, and yeah, those 6 antigens. So subsequently, what has happened is that more vaccines have become available, and the trend of more vaccines becoming available keep on increasing as the field of medicine advances. And you can see, starting with 1 vaccine in 1950s, then 6 antigens during the initiation of EPI in 1974. What we picked up was that the coverage, for example, for DTP3, which is the 3rd dose of diphtheria, tetanus, and pertussis vaccines, and used as a proxy marker to assess the performance of immunization program, the coverage went from 5% all the way to up to 80% in around 2010. But since then, most countries have reported, especially low and middle income countries, have reported stagnation of coverage. And with COVID, we actually even observed some dip in coverage of DTP3 and many other vaccines. And there are many other vaccines that are available, which are not routinely used in all settings. For example, influenza, varicella, hepatitis A. And then we also have future vaccines, which are already, some of them are being rolled out. For example, malaria, Ebola, RSV, TB, and HIV. So as more vaccines become available, the programs that need to take up these vaccines, it has become clear you cannot just add a vaccine into the program because it's available. You need the use of evidence to show that actually you need that vaccine, and if you need it as a program manager, how do you going to make sure that you gain the maximum benefit out of it? So so some of the factors that have been driving the evolution of national immunization programs, I've talked about new vaccines, but also there's changing epidemiology of vaccine preventable diseases. For example, yellow fever virus, it's a virus that has been shown to go into areas that, or to be infecting people in areas that it wasn't infecting before, and largely because of climate change. Also, the emergence and re-emergence of infectious diseases has been observed, pandemics, with COVID being a very good example. Also, issues like socioeconomic development. For example, some countries that were considered to be endemic for hepatitis A are no longer endemic, and we're seeing transition because of socioeconomic development of some diseases. And obviously, public health emergencies, especially in countries that have large or frequent conflict, we're seeing less population immunity in these communities because it's hard to take vaccines to areas which have insecurity. And the result is that we're seeing more and more outbreaks of vaccine-preventable diseases in these settings. And that requires immunization program to start doing what we call supplementary immunization activities, and also requiring the immunization programs to do catch-up immunization activities. And then also I talked about eradication and also elimination and control vaccine preventable diseases, which is what vaccines are supposed to do. And I'll speak to that in the next slide. Another factor driving the evolution of national immunization program is the global immunization framework. The current framework that we have globally, it's called Immunization Agenda 2030, and I'll speak to that. And then another important aspect is the National Immunization Technical Advisory Groups, and this centrally touches to the NISH work, which I'm going to speak at the end. So I will speak a little bit more about the bolded point, which are some of the factors driving the evolution of national immunization program. So with eradication, elimination, and control of vaccine preventable diseases, which is what vaccines are supposed to do, what we notice is that anytime you've got a high incidence of a vaccine preventable disease and there's a panic in public, by the public, then you see that people really want to get vaccinated. And once you bring in the vaccine, there's rapid high uptake of the vaccine. And with high uptake of the vaccine, then you see the incidence of the disease declining. So with that increased coverage, then you realize that the disease incidence declines because you've controlled the disease. And then the public cannot see cases of the disease, and there is loss of confidence. And with loss of confidence, then the result is a decline in coverage. And that is when we see outbreaks of vaccine preventable diseases that are already controlled in communities. So there is this relationship between maturity of the program and incidence of vaccine preventable diseases. And this is why national immunization programs need to be quite aware of this relationship and modify based on the evidence available to make sure that these outbreaks don't occur. So it's very common to hear most immunization programs undertaking catch-up to sustain community immunity to ensure there are no disease outbreaks. Then with global immunization framework, the current one for 2020 to 2030 is called Immunization Agenda 2030, and it has several strategic priorities and core principles. So the priorities are the commitment and demand to make sure that immunization programs are able to generate demand for vaccines by communities, and then ensure that vaccines that are available, the coverage is high and equity is achieved. And something that is very important is realization that vaccines are not just for the younger population, but for everyone, which is called the life course approach to vaccination. And I'm going to speak about that in the next slide. Then also to make sure that population immunity to vaccine preventable diseases is sustained, it's important to focus on outbreaks control and also use of vaccines during emergencies. And key to this is not just being reactive to outbreaks, but being able to predict those outbreaks and ensure that it's preventative approach. Obviously, a key aspect, and this was seen with COVID, is the issue of vaccine supply and sustainability. So to ensure that communities have high uptake of vaccines, then we need to make sure that there is no stock out and supply is stable and sustainable. Critical, and which I think is very important to the audience here, is to make sure that research and innovation advances immunization. So those are the strategic objectives, and the core principle is that immunization agenda needs to be people-centered, meaning that people need to own it, countries need to own it, and a stakeholder for country ownership is actually NITAGs, who are supposed to foster ownership of immunization programs by government, and I'll speak more about NITAGs. The program needs to be, a core principle is that immunization agenda is to ensure that there's partnership and finally evidence-based, which is data guided. And the project that I'm going to talk about is pretty much focused on NITAGs with the aim of advancing country ownership. And also I will highlight at this stage that the project that we do has a lot of partnership with many other global stakeholders that support NITAGs. And it is also data guided, which is central to EIDM, which I introduced to you earlier. So I've talked about life course approach to vaccination. So when I talked about the EPR starting in 1974, the focus then was to actually vaccinate childhood population. And that makes sense because children are more vulnerable than adults when it comes to infectious diseases, because the immune system is still adapted to the in utero environment, and they are at higher risk of acquiring and also developing severe morbidity and mortality because of infectious diseases. But what evidence has shown is that you can actually use vaccines beyond infancy to optimally get the best benefit from the vaccines. And the life course approach speaks to having vaccination services provided to pregnant women, not only to protect pregnant women, but also to protect young infants who haven't reached the age of vaccination yet. And then stick to vaccinating infancy and early years, and then also childhood and adolescents, 5 to 24 years old, working age, and older people. So the mantra for Immunization Agenda 2030, which led to this strategic goal, is leave no one behind. Make sure that everybody can benefit from these life-saving interventions. So to ensure this, and this creates an additional complexity to the immunization program, because largely the program has been designed to deliver vaccines to children, because there's frequent contact of young population with the healthcare system, which is not very common with adolescents and working age and older people. So how do you redesign, how do you use evidence to make sure that the adolescents and working adults, as well as the elderly people, have access and get vaccinated with available vaccines? So one of the approach that has been proposed, and which is the current practice and advocated for use in the future, is to use evidence to recommendation process when it comes to making decisions for immunization and vaccines. And the process has 4 steps, which is first formulating the policy question. And usually this policy question can be raised by the government, Department of Health, or it could be initiated by other stakeholders, including researchers who possibly have some linkage with the program, and then look at different elements that are needed to address the policy questions, and then collect the evidence and then make a recommendation. And I want to flag an example of a policy question that as a group we addressed, and this was actually a PhD project for one of our students who graduated this year. And the question was, should the hepatitis A vaccine be introduced into the South African expanded program on immunization? So once you ask that policy question, then you define what kind of elements you need to collect to answer this question, and generate the evidence, appraise the evidence, and then make a recommendation. So with evidence, it's a process of collecting and looking at the quality of the evidence, especially when it comes to the benefits and arms of the vaccine. We're talking about the efficacy, effectiveness, also adverse effects following immunization. And then once all this is collected, analyzed, then you look at the balance between the benefit and the risk, and then a recommendation is issued. I think a very critical aspect to mention here is that this process needs to be contextualized to the local setting in order for that decision to be applicable. And whereas WHO position papers use this approach to make a global recommendation on the uses of vaccines, each country needs to adapt this position paper recommendation to their setting by using this process. So when it comes to the domains that one look at when answering a policy question, the first thing is to make sure that the policy question is specific. For those of you who are familiar with evidence-based practice, the thinking is that the policy question needs to be made specific, and the guideline for that specificity of the policy question is by using what we call the PICO element, which is the population, intervention, comparison, and outcome. So population meaning that you look at the population of interests for the question, then intervention is the vaccine that needs to be considered, and outcomes, this could be, for example, reduction of morbidity or mortality, and then comparison is if there's an already existing intervention targeting the same vaccine preventable disease. So with evidence to recommendation process steps, there are 7 domains that are considered, and this is first looking at the problem. Is the disease a public health problem? Then look at the vaccine that you want to make a recommendation for in terms of benefits and arms, and then look at the values and preferences of the target population. Look at whether the vaccine is going to be acceptable to the different stakeholders that are involved in that policy question. And importantly, look at the economics of the vaccine in terms of resource use, equity, a very important aspect, and look at the health system, whether it's able to ensure visibility of implementing the recommended policy. So the last part, so I've talked to you about the EIDM application in vaccinology. I've highlighted to you some of the evolution aspects of the NIPs, and I've given you a snapshot of the evidence to recommendation process. So I'm going to give you a bit more of a snapshot of one project that VACFA is undertaking, which is the NISH project. So the premise to this project is that evidence-informed decision-making is advocated at global, regional, and national level by WHO, and also government are committed to this. And specifically at country level, what is required is that the Department of Health should have national immunization technical advisory group, and this is a group that consists of independent experts that are supposed to provide evidence-based advisory role to the Department of Health. And what is critical about NITAGs is that it consists of professionals of diverse expertise. You could have social and behavioral sciences professionals, you could have people with health systems background, you could have epidemiologists, you could have microbiologists, health economists, and so forth. So you need to tap into that diversity of expertise to issue an evidence-based recommendation to the Ministry of Health. What happened in 2018, the World Health Organization and Wellcome Trust identified, following a workshop that was held in UK, they identified that in the future, NITAGs would need support in different areas in order for the NITAGs to function optimally. And one of the areas is the financial resources, especially in low and middle income countries. Then issues around experience sharing was seen as a critical aspect of NITAGs. And capacity development, especially with the application of evidence to recommendation, and also access to tools and research evidence to ensure that NITAGs could use these tools and evidence for EIDM in their context. So what we hypothesized at VACVA is that to ensure NITAGs get the most support, then we could have an academic-based project which could support NITAGs in Africa. And just a short background to this is that in Africa, which is a continent where NITAGs setup has been quite slow compared to other regions, even in countries which have NITAGs, there has been need for them to get some sort of exposure to different types of training that could support them in their evidence to recommendation work. And we hypothesized that setting up a hub would give evidence-informed decision-making support to NITAGs, and that would accelerate these groups in reaching optimal scientific level that is going to help them be better at advising their government on issues around vaccines and immunization using evidence-informed decision-making approach. So we had some discussion with Wellcome and with WHO about this idea, and they said, well, we can fund you to look at the visibility of this idea. And we got funding, and what we did was to look at the literature and reach out to these NITAGs members and ask them whether this idea, they would support it, and if they do, what kind of work would they want the project, the NISH project, to do. And when we ask them, we reached out to them through online survey, because this was the time actually we were on lockdown, it was 2019. And we reached out to 29 out of 30 countries that had NITAGs then in Africa, and we sent questionnaires to English-speaking countries, French-speaking countries, and Portuguese-speaking countries. And we got a response from quite a number of them. Over 60% of NITAGs responded to our survey questions. And what is pleasing was that close to all NITAGs that responded to our questionnaire supported the idea of setting up NISH. And also, when we ask them the kind of evidence-informed decision-making support that they have currently, either from their other groups within their country or from partners and other stakeholders, it was clear that training was much less available. And more importantly, they indicated that support in using mathematical modeling or even economic evaluation for evidence-informed decision-making was lacking. And these are kind of information together with what NITAGs told us through workshop that we had with them that informed the activities that this project would subsequently undertake. So from this survey and also from a workshop that we conducted, as well as the evidence from literature, we were able to put a proposal together to set up a NITAG support hub or NISH, and also identify what will be the key activities for this project here at the School of Public Health. And this is so we submitted a proposal to set up NISH, which was funded in 2021. And this is the operational and governance model. So we have our key users of the project activities, which are the NITAGs themselves. Then how do NITAGs access the services provided by NISH is through WHO, who is a very key and close collaborator to NISH. And then we setting up a help desk on our website, which I'm going to show you in the next slide. And then these are the key core services that the project was asked to give by NITAGs. So training in evidence-informed decision-making and also support, vaccinology training, and also health economics support, mathematical modeling, health systems, and design thinking, as well as research. And research is important because what NITAGs in our setting indicated was that there's very limited local evidence to help them make decisions, which is locally relevant. So there was thinking that there's a lot of global data, but less so at a local level. So then we started this project in 2021, as I said, in July, when the project was funded. And beginning of this year, we launched the NISH website, which you can take a look at some stage. These slides will be shared with you. And the idea of this website is obviously to help us engage with NITAGs, keep engaged with them, and also importantly make sure that we do not just work for them, but work with them in order to support them with their activities of issuing high quality and timely evidence-based vaccines and immunization recommendation. So because of time, I think I'm gonna go into the summary slide in terms of future application of evidence-informed decision-making in the context of evolving national immunization program. So this method, which is evidence-informed decision-making, can be used in optimizing vaccines programs. Because we are seeing more and more vaccines available. So it's not like in the old days when you had only one manufacturer giving, making one vaccine available for a specific vaccine, preventable diseases. Like you've seen with COVID, there are multiple vaccines. And looking back, a lot of optimization can be done on the use of available vaccines. And then this approach is very important in prioritizing interventions. Think about different vaccines being available. How do you prioritize which vaccines need to be introduced first? So you can apply evidence-informed decision-making for that. And then navigating the use of resources that are available, because inevitably we operate in a resource-constrained environment. So this links to prioritizing intervention by looking at the resources available. And then strengthening capacity, especially for impact evaluation, and also making sure that decisions that are made have better implementation process. So I think that's the last slide that I have, and I thank you. I think we've got a few minutes for questions. Melina was taking questions from you in the chat. Do I have any questions in the chat?
Not yet, Ben.
All right. Thank you. So I'm happy to take questions from in person as well as from the online participant. All right. Yes?
Can I ask a question? Thank
Sure.
you very much. Very informative talk. I mean, evidence-informed decision making, why are we not applying it across the board? Why are you restricting it just to vaccine information? I mean, surely in the context of advanced HIV disease, what strategy should we be implementing as a country and so on? Does it not all sort of need to go through this process? It's more a comment, I think. I think it's a really good and rigorous way to go through things. And on the same vein, if you are then supporting sort of vaccine implementation or decision-making initiatives, can't we broaden that, to more general, other health-related? I'm just finding it so siloed. We're just looking at the vaccines.
No, you absolutely.
Maybe just repeat the question to the online group, just in summary, because they might not have found it.
Oh yes, good suggestion, Melina. So the question or a comment has been made that this EIDM process, it's rigorous and it looks the right way to make decisions. Why should it not be extrapolated to other healthcare, health priorities, like HIV and possibly TB and also poverty, and it's almost like you spoke to the funder because the funder said that in terms of sustainability, we need to see how this process, in addition to supporting immunization, can be expanded to other healthcare activities, including HIV. And I think the reason why we needed to first concentrate on immunization was, that is what we do, and that was the problem that we had at the moment. And the funder and the stakeholders seemed to be all in agreement that that was a priority. But clearly, we've managed to look at the landscape of EIDM, especially on the continent, and it's being applied in many diverse sectors, including agriculture. But the immunization field seemed to be, just because of coordination from global, regional, and national level, they seem to have come up with sort of a very kind of accepted structure at different levels. And I think it's all about making sure that we also interact with other sectors. So I fully agree. And part of sustainability of this project, the funder and us have agreed that we need to expand beyond the immunization when it comes to application of the EIDM. Yeah, yes, Lucy.
Thanks very much, Ben. It's good to get a good overview of everything. So I'm interested in a way, the role of the NITAGs in supporting implementation and what evidence would be relevant to that. And maybe their role is mostly to recommend to government that vaccine X is appropriate to be included in vaccine schedules and rolled out nationwide. But you've used the phrase implementation, so I'm wondering what the implementation issues are that NITAGs consider. And when we think about those implementation issues, then your hierarchy of evidence would be inappropriate, I would think, in terms of the evidence base that you might draw on. So I wonder if you could comment a little bit on those issues.
Yeah, so the question is on the role of NITAGs in terms of recommendation and not just recommendation, also in terms of implementing these recommendations. And what is interesting is that although NITAGs in terms of composition, there is pretty much a standard way of setting them up. Because they're independent and they're supposed to work with government, without the government buy-in, NITAGs would not do anything. So some countries, for example, Australia, and I think even Canada, the work of NITAGs is actually incorporated into the constitution, that whatever they do, government has to do it. But that is not the case with most African NITAGs, where you make a recommendation and the government says it's up to me to decide whether I take your recommendation or not. So you're right, they're not involved in implementation, but there has been more and more advocacy to make sure that, can they be involved beyond recommendation? And also from the NITAG's perspective, you want to make sure your recommendation takes into account issues around recommendation, because you don't want to make sort of hypothetical recommendation, even with the best evidence, that it's not going to work. So the question is, how can NITAGs and government work together with this evidence to ensure that the EIDM approach they use and recommendation they make sense in terms of implementation. So implementation science is becoming critical, and I think NITAGs are finding themselves active in this space. So it's an evolving.
There's a question on the chat, Ben, about hoarding of vaccines by wealthy countries. What is the prospect for low-income or clusters of low-income countries, middle and low-income countries, to develop their own vaccines? Is it desirable? Is it feasible? Is it something that's just impossible to actually surmount?
Yeah, I think that's a good question, and I'm sure most of you remember about vaccine apartheid during the peak of COVID pandemic, when rich countries had access to different types of vaccines, whereas poorer countries did not have access to any vaccine. And for Africa continent specifically, there was a huge effort to ensure strong partnership was created. And this partnership, led by Africa CDC and other key stakeholders, were aimed at ensuring that the continent relook at the way it sources vaccines. Because if you rely on the rich countries, you'll always be behind the queue in terms of accessing the vaccines. So there seems to have been a realization that, poorer countries, especially low and middle income countries, need to do something. And it has been a very active space in terms of setting up vaccine manufacturing capacity for low and middle income countries. And to me, I think it's a space to keep watching, because vaccine manufacture and sustainability is not an easy. I'm not a business person, but it's not an easy thing. I would have assumed that all African countries come together and support a few more initiatives, and not each country does its own manufacture, because we are a continent that, possibly the birth cohort is, let's say, maybe about 1 billion per year. So for you to have that cohort to sustain in terms of vaccine manufacturing, you don't need every country manufacturing a vaccine. And we can learn from China, which has a big birth cohort. They have been able to set up their own manufacturing capacity that, sees to the needs of that big population that they have. So COVID as bad as it was, the positive side was that issues around vaccine manufacture and equity became more prominent, and I think there's a lot of optimism going forward in terms of how access to vaccines can be improved for these low and middle income countries.
Perhaps one last question from the chat. How have mathematical modeling groups supported NISH work to date? And are there further prospects for existing and future collaborations around mathematical modeling?
Very good question. And I will take this opportunity to actually invite the community within the School of Public Health and others to partner with us, because we need to use different disciplines when it comes to evidence-informed decision making. And with mathematical modeling specifically, we have the Modeling Support Hub, which is based at the School of Statistical Sciences. Shito is working with us. And what we've noticed, and not just NISH, but this is pretty much a low and middle income countries' challenge, is that people cannot use mathematical modeling and health economics if they do not know how it can be used for decision making. And whereas the funders and policymakers, actually maybe funders and researchers, see the value in health economics, mathematical modeling, the request for this kind of service hasn't been forthcoming from NITAGs. And we've realized that it's only going to be possible if more and more advocacy, more and more training is done to NITAGs on how these fields are usable in the context of evidence-informed decision making. So the Gates Foundation has a workshop, 2-day workshop, that is happening in Kigali the first week of June. And it's to bring policymakers together, researchers together, and all other stakeholders to ensure that more and more can be done with available mathematical modeling and health economic support in order to ensure that policymakers, not just in vaccines and immunization, but also in other sectors, tap into these fields for decision making. And I'm that workshop. So I will be able to also make a case that we need more and more advocacy to utilize these fields when it comes to evidence-informed decision making.
Just one last question, because she did try to ask earlier, is the Aspen Pharma Care plant in Kabeja not a good example of government taking initiative to manufacture vaccines for Africa? Do you have any opinion on that thing?
It is. I mean, I don't have much insight except that, I mean, Aspen was one of the very first African local manufacturing facility to start fill and finish activity for COVID-19 vaccine. But you remember it was in the news that at some stage they couldn't have market for those vaccines. So it's not just about making those vaccines, it's also making sure that it's sustainable by having a market that you can supply these vaccines to. Also BioVac, which is just across the road here, it's another example. So, you know, there are, you know, highlights in terms of what is feasible, but in terms of sustainability, I think there is more to be done with respect to local manufacturing capacity.
Just one question I was wondering about, when the NITAGs think about their recommendations to governments, they obviously think in terms of public health policy, but how often and how much do they also look at the private sector that may exist in some countries and may have a fairly big role in terms of vaccination as a sub-sector of the population, where there may be recommendations that's not feasible or appropriate for public health, but that is feasible within the private sector, and if they, you know, do make that part of their focus as well.
good question, especially in South Africa, where 20% of the public are using private healthcare. So in terms of composition, you'll see that the private sector is represented in the NITAG membership. So you'll have the president of, for example, Pediatric Association being in the NITAG. But it is a good question, and for equity purposes, the NITAG's recommendation really focuses more on to the bigger sort of proportion that access the public healthcare. But for example, a good example is hepatitis A, the PhD policy question that we ask. Currently, hepatitis A vaccine is available in private sector, but it's not recommended by NITAG because of the problem hasn't been seen as a public health priority based on many other public health priorities there are. So you see that there is the NITAG will issue a recommendation thinking more of the bigger population that access healthcare. But should a policy question that touches into the people accessing a private healthcare comes in, then NITAGs have the prerogative to decide whether this is something to take forward or something that shouldn't be taken forward. But it's a good question. Right. Thank you so much. I think all right. Thanks all for joining us online. We end and take care. Have happy Easter holiday. Thank you. Bye.